When I got this topic, I was a little thrown because it's going to be a lot of this is what I do kind of talk rather than the more sort of systematic scientific approach. But it did, I think, for all my preparations, this is the talk which I had to think a lot or review my practices the most compared to the other thing. Now, I think most ICUs investigate a lot, and the practices are extremely varied. But the reasons they investigate a lot is that we perceive a benefit that we diagnose a problem right when it's starting, not when it's become a full-blown problem. And hopefully by doing that, we act appropriately and quickly, and therefore we prevent complications from occurring. And this overriding principle probably applies to every part of critical care, not just the frequency of blood investigations. But like everything else in critical care, this comes at a cost. The cost is financial. The cost could be blood loss. It could be painful for the patient to have multiple punctures. And the more blood is collected, the more needles are used, the more chance that one of the staff might get a needle stick injury and some sort of blood-borne infection. So we do obviously have to find a balance. I'm not going to spend too much time on this except to say the costs are fairly substantial. These would be what the standard investigations in my hospital would cost. And if you just look at the bottom line, if you're a unit which happens to do CBC, some sort of coagulation, liver, kidney and sugar function tests on a day-to-day basis, it would cost between 5,000 and 10,000 in our unit. If we pare it down just to the CBC, a couple of electrolytes, BO and creatinine sugar, it will come to between 5,000 and 10,000. And so we are talking of, I mean, it won't break the bank, but we are clearly talking of a substantial amount. We need to keep that in mind. If we use biomarkers, that will also further add to the cost, and I've listed some of the biomarkers we use. And if we use a shock sort of group of biomarkers, it will cost about 5,000. Dyspnea were about the same. Cardiac is a little less. So I've just put up the slide to say that we need to keep these numbers in mind when we prescribe investigations, especially if they're frequent. I also remembered in my early days of critical care, that was the 4th conference in Pune. The nurses did this project. It was in the early days when we were trying to get a little systematic. And the question they asked is, how much blood do our patients actually lose when we collect it? Again, this is 1998, a fair amount of time back. But they very systematically kept a form at the bedside of each patient, and they looked at the amount of blood being collected for every investigation. And they recorded it. And to our surprise, not really our surprise, because it turned, most of the patients are high turnover post-op patients. The total blood loss in the ICU stay was just 85 cc, but the daily was about 40. So people who stayed longer might have had a more substantial blood loss. At that time, 25% went for hemat, 50 for biochem, and another 25 for blood gases. So the conclusion was maybe it's not as much as we think it is, especially in those who spend just a few days in the ICU, because people talk of anemia, of blood depletion and so on, and that didn't appear to be the case. To take it a little further, how much do we actually send nowadays? We send 2 to 3 cc for hematology and about 3 to 4 for biochemistry. We could ask the pediatricians, because they obviously need to save blood much more. And we went to the PICU and they use about half what we do. Now keep in mind that they get quality of reports pretty much the same as ours. We could ask, why can't we send half the amount of blood? There also appeared to be a little divergent practice in whether we should return the dead space blood or not. In the adult ICU, at the request of the infection control, we don't do that. While in the pediatric ICU, if they get a sense that if they don't feel there's any clot or anything, they return the blood. So why can't we use the pediatric approach to all ICU patients and save a lot of blood? I went to our lab person and asked, and effectively it's really a logistic issue. They don't need much blood. You can get pretty much a full liver, kidney, everything profile with 380 microliters of serum, which translates to less than 1 ml of blood. And you can get half that if you just want the basic profile. The problem is logistic. The microtainers for pediatrics don't fit into the trays, which then fit into the autoanalyzers. You have to keep transporting blood from one vial to the other. The barcoding safety is lost. So for these various reasons, they don't do it. But the point I'm getting is that we could probably collect even less blood than we are if the autoanalyzers and the vacutainers and the microtainer system allowed us. It's not a question of actually analyzing it. It's a question of other issues. This question clearly has been addressed in the past, and in this paper, which is fairly widely cited, there were 4 recommendations. 2 on recommendation to blood control is use micro techniques and try to use indwelling reservoirs. We are not seriously using either of them right now. This is what I would consider a fairly routine set of investigations, especially when the person first came to the ICU. We'd do a full hematology with the coagulation. We'd pretty much do a full biochemistry with the LFT. And depending on what we think the other problems are, we might do some microbiology, some imaging. Also, as I said, biomarkers are becoming more and more routine, and I think we've been using CK-MB troponin for decades. But we are fairly free with using procalcitone and for septic patients, and in the dyspneic patient or the shock patient, we might use D-dimer or pro-BNP. And maybe these have to be repeated. If I was to say that our practice has changed a lot over the last 10 years, it would probably be in the era of blood gases, in the area of blood gases. For a long, long time, it would be fairly standard to do a morning and an evening blood gas on all ventilated patients, plus after changing the mode, plus if anything new happened. That would be the default blood gas plan. It would happen by itself if no one requested otherwise. Obviously, during weaning, when you move to the weaning mode, you might check the gas, you might check it on the T-piece, and you might check it after extubation. So this would have been the practice, and it does appear that on a sort of loose survey of many ICUs, the average daily blood gas does appear to be between 2 and 5 to 6, based on all these events occurring. Clearly, we are changing. If at all I can say with some confidence something is changing in our ICU, it is that we are using blood gases less and less and less. Number one is, for practical purposes, pulse ox has become universal from being just available to be taken. Everyone has a pulse ox on all the time, whether they need it or not. So we have the possibility of monitoring EtCO2 also, but it's nowhere near as universal as saturation. It's only used on an as required basis. We have, for whatever reason, and I think we have done it fairly safely, come down to once a day routine gas. I mean, for the average ventilated patient, we don't get an evening gas as part of the routine, only if an event occurred or a ventilator change occurred. And one of the things I like to stress more to residents really is that regardless of the gas, we need to go by clinical above the gas. So, for example, a COPD patient, I am very happy not doing blood gases at all. I don't want to know the CO2, because the CO2, if it's 75 or 80, people might slow down the weaning process when in my view it's unnecessary. Sometimes some of my colleagues, either from my department or from the pulmonary department, request blood gases. I feel we're slowing down things rather than speeding them up, because we're giving too much information, too much importance to this information when we could fairly safely wean clinically. Similarly on NIV, I don't think we need to make blood gases, we need blood gases to decide that the trial has failed. We can just look at the patient, the person is fatigued, the person tells you they are fatigued, and we don't need a blood gas to make any further listing. Equally important is getting a false reassurance that because the blood gas is okay, everything is okay. So sometimes I get a call that the person's not looking good on NIV, but don't worry, the blood gas are okay, and I think this is a misuse of blood gases. So I recommend that in many situations we should be making decisions clinically rather than with blood gases. And for these various reasons, I think our blood gas utilization is probably about 30 to 50% of what it was a decade ago. Okay, so this is, I think, the first major area of change. Okay, now if you see, the cost of a full routine biochemistry would be 5,000 a day, which is a fairly significant amount. I know many hospitals do some LFTs, some renal functions and some electrolytes on a daily basis. And as best as I can make out from my reading and from speaking to people, this is just a practice which continues. I happen to work in different hospitals, and they're clearly just different practices which just happen by themselves. The argument for doing all these tests daily is that they do allow you to diagnose liver dysfunction and renal dysfunction early. Our practice, again, probably for more than 5 to 10 years now, is to limit the biochemistry to the 2 electrolytes only, sodium, potassium, the BUN creatinine, and the sugar. But as I said, I work in different ICUs. Most ICUs measure the chloride. I don't think a routine chloride is required. We do need it for anion gaps and so on, but I don't think we need it daily. Some ICUs do creatinine without BUN, not to save money, that's just their pattern. I'm quite uncomfortable with this particular thing, I need the BUN. But having said that, I work in the other hospital and they seem to be doing as well or as badly as us. So I at least need to reevaluate whether we need the BUN and the creatinine, but I still do both on a daily basis. I don't normally do the bilirubin, SGOT, albumin on a daily basis, but would consider it if there was an element of liver dysfunction as part of the multi-organ failure syndrome. Clearly, if the person had a primary hepatic disease, we'd be doing it more frequently. CBC, I think it's universal. Everyone gets it daily. I don't think there's too much variation here. And it doesn't even cost too much. Coagulation, for some reason in our hospital, costs quite a lot of money. And again, I know many ICUs and all the ICUs I trained in abroad did it daily. But this is also going to add a fairly substantial amount to the cost. And our practice for a long time has been do it when you need it. But pretty much no one gets a daily coagulation profile. They may get it when there's a major bleed and for a day or two after that, or if there's a massive transfusion. And as was discussed in the earlier session, possibly we should be moving towards more mechanical evaluation of the clot with the TEGs and the viscoelastic properties rather than on the lab. A word about biomarkers. I think they are useful. And I would just say that I'm learning my way through them. I think you really learn or you get a feel of how useful a biomarker is only after you use it for a certain amount of time. The first thing I think they're useful is if they are negative, they sort of help you exclude certain of diseases. They're more useful as negative predictive than as positive. Unfortunately, to use biomarkers well, you do need to do them frequently, which of course means the cost goes up. I'll just give you a simple example. Let's say a person with a myocardial infarction is admitted to our ICU and he requires ventilation and inotropes for 3-4 days and he gets better and he's extubated. And in a similar way, a pneumonia patient gets admitted to the ICU and requires ventilation, requires inotropes and gets extubated over 3 to 5 days, let's just say. And on the 7th or 8th day, there's a new patch on the X-ray and there's hypotension and we want to know if this is septic or not. If the PCT, the procalcitonin, happened to be 25, it's pretty difficult to interpret in the pneumonia patient. Because if it happened to be 100 at the time of the initial admission, 25 suggests it's not a septic complication. If it happened to be 10 at the time of the initial admission, 25 suggests it is a septic complication. So I think we need to at least I still need to figure out what is a good way to use biomarkers so that I get meaningful information and yet the cost doesn't escalate. And obviously each biomarker has its own half-life. And the shorter the half-life is, the more useful it is for us in the ICU. The longer the half-life is, the less it tells us. For example, a TROP-T is positive for 7 days. So if a person comes to you on the 4th day with a setback, you really don't know if it is myocardial or not. Similarly, as I said, false positives are common in systemic inflammation, in renal failure, and liver failure. So the negative tests are generally more useful than the positive tests. There was a time we were doing tight sugar control. The Vandenberg protocol was to use it to the labs for the sugar, but we happened to use the stick. Obviously, if you're following the Vandenberg protocol and you're not returning dead space, there's going to be a fair amount of blood loss to follow that particular protocol. And I think that plus cost was the reason, and of course the speed of the getting back the answer was the reason we chose glucose stick as the way to go about it. But as after the NICE study, our range of sugar control has relaxed and therefore the need to do these tests very often has also become significantly less. In the Vandenberg protocol, it was hourly for the first 4 hours and then 2 to 4 hourly depending on what was happening after that. Other tests, questionable value, I mean obviously we do them off and on in different clinical situations, but most of them don't need frequent repetitions. Some patients get stuck in the ICU for weeks and weeks, Guillain-Barré's, head injuries, strokes recovering. And once we are happy that they're in the rehab phase rather than in the critical illness phase, when they're in the nursing phase rather than the medical phase, I switch to alternate day investigations initially, then we go to twice a week, and then we go to once a week till such time as the patient is transferred out. So I just conclude by saying that frequent tests are probably necessary, and they further add to the cost of what is already generally a costly place to be in. Micro techniques exist, but are not universally used, more for logistic reasons than for anything else. And at least in our hospital, we appear to have slightly different protocols for blood returning in the PICU and the adult ICU, suggesting that we are probably a little more casual about throwing away blood than the pediatricians are. I think the initial investigation should not be sort of ration. We do need to initially investigate extensively to make sure that we got a grip of all the problems the patient is facing. But in my practice, and probably in most people's practice, the trend has been either continue the same or get less. Possibly we all need to go back, and possibly we need to ask ourselves, it's become too much of a routine sending off these investigations. I couldn't find any outcome-based results, and I think it will be extremely difficult to actually do these studies. And again, outcome-based results is a little difficult to interpret in terms of relatively vague questions like frequency of lab monitoring. But till then, we could at least ask, do we really need this test? It's embarrassing how often you don't know the price of the test you ask for. And just knowing the price of the test might sometimes make you a little more rational about using it. And it's, again, worth asking, will I actually get a diagnosis by doing this test or not? I think we should be rationalizing, but I think we are pretty liberal. I think we do more than we need to. And I think that's all I can say on this topic, which is probably a practical and pragmatic and important topic, but not well studied and not well addressed. Thank you.